Everyone, welcome back. So our next presentation is behavioral health integration into primary care. So before we get started, we're going to go through the housekeeping again for those of you who are just joining. So the audio will be muted for all attendees as well as video. Please put technical questions into the chat and comments. And any questions for the panelists will be in the questions, and we will hold those to the end of the presentation. This webinar is being recorded, and you can find the handouts on the attachment. So to kick off this presentation, I'm going to pass it off to Kate Mundell. So Kate is the Director of Provider and Community Relations at Coordinated Care of Washington. So Kate, the floor is yours.
Great, thanks Stephanie. Good afternoon everyone. So I have the pleasure today of introducing Dr. Julie Richards and Dr. Bridget Beachy to you today. We're going to walk through behavioral health integration into primary care. Julie comes to us from Kaiser Permanente, the Washington Health Research Institute, as a research associate, and Bridget comes to us as the Director of Behavioral Health for the Central Washington Family Medicine Residency Program. Both bring extensive years of experience and knowledge to the table today, and so we're very excited and honored to have them with us. And with that, I'm going to hand it over to Julie to get us kicked off.
Great. Thanks so much, Kate. It's really nice to be with everybody today. I'm a researcher at Kaiser Permanente, Washington, and I'm actually here in my office in downtown Seattle today. So I'm really hoping for a stable internet connection. I'm going to be telling you about our efforts to integrate mental health in primary care. Many providers and staff were involved in this effort, including some of you on this call. So I want to start by acknowledging that this was a massive team effort. I also want to acknowledge that some of the material that I'll be presenting today might be a little difficult to hear, particularly if you or family members have had personal experiences with suicide. I've heard many researchers, myself included, that sound a little automated or use language that reinforces stigma, and I'm going to try not to do that today. Hopefully we'll have some time for questions at the end, but if you have any technical problems or you're not comfortable asking a question in the setting, feel free to just send me an email anytime. Next slide, please. So I'm going to start off by telling you a little bit more about me. This is pictured here as my mom more than 10 years ago. She died by suicide in August of 2010 when my daughter was about a year old. During a particular low point several years before her death, she was experiencing severe depression and suicidal thoughts. At that time, she was hospitalized for inpatient psychiatric treatment. She lived out of state, and I flew to Las Vegas where she lived. That was my first experience really struggling to navigate the mental health care system. She seemed to be interacting with a lot of care providers, but nobody who was truly responsible for her care. In the psychiatric facility where I visited her, I never actually saw a provider or was able to ask any questions. My mom seemed really over-medicated and could really only communicate her most basic needs. For example, she asked me to bring her a pair of glasses or a sweater when she was cold because it was so cold in her room. There was no clear treatment plan, and when she got out, she basically left with a big bag of meds and no follow-up plan in place. She really hated that experience, and she told me that she would never go back to the hospital. Personally, I think that experience likely contributed to her death several years later. So that's one of the reasons I'm here today, and that's why I think the work that I'll be describing is so vital to the individuals, families, and communities our health systems serve. Next slide, please. These are the key points that I hope you'll take away from this presentation. Providing team-based care for mental health and substance use is feasible in primary care. Resources are available now to help primary care teams do this work. Next slide, please. So mental health integration at KP Washington officially began in 2016 and finished in 2018. Up until COVID began, most of this work was done in person, but over the last few months, KP Washington has converted much of this work so it can be done virtually too. Integrated care starts with annual screening. Individuals seen in person receive a 7-item questionnaire, which includes the PHQ-2 for depression, the Audit C for alcohol use, 2 questions on cannabis use and other illicit drug use or non-medical use of prescription medication. Individuals who are seen virtually receive a similar questionnaire securely through the KP Washington online platform. When data from the screen are reviewed, there's additional severity assessment tools that are available to guide clinical decision making. These include self-administered checklists for alcohol and drug use disorders, as well as a suicide risk assessment. Clinical social workers are available to support primary care teams for patients with immediate needs like suicide risk and engage individuals in collaborative planning and decision making. And I'll talk more about that in just a couple minutes. Patients who are diagnosed and receive some form of treatment for depression or substance use disorder are also monitored at subsequent visits to measure symptoms over time. Next slide, please. 3 main implementation strategies were used during the rollout of integrated mental health care, enabling, supporting, and performance monitoring. Practice coaches met with local teams at each primary care clinic to help enable workflow implementation. Electronic health record systems were designed to support clinical decision-making, and performance monitoring metrics were developed to help leaders and local teams monitor mental health integration. Next slide, please. The practice coaches were the main link to the clinical teams and shared their experiences and perspectives across the teams involved in supporting mental health integration. Once implementation ended, operational leaders really shifted into this position of being the main link between the teams. Next slide, please. So here's an example of what the workflow looks like for depression for adults. There's a separate workflow for adolescents that's being integrated in the primary care clinics now, which is a little different than what I'll be describing today. And if you want more information about adolescent mental health integration in our health system, please feel free to send me an email. So now, whenever an adult has a primary care appointment, the electronic health record fires a prompt for mental health screening at least annually. The first 2 questions on the screener are for depression. Those who answer more than half the days or nearly every day on either of these questions are asked to complete the full PHQ-9 depression severity assessment on the back of the screener. Next slide, please. Those with frequent suicidal ideation, defined as a score of 2 or 3 on the 9th question of the PHQ-9, are asked to complete a self-administered version of the Columbia Suicide Severity Rating Scale. That questionnaire is shown here. When questions indicate intent or planning for a suicide attempt in the prior month, that's a yes on question 3 or higher. Providers are prompted to make a same-day referral to a clinical social worker for same-day crisis response planning, also called safety planning in many health systems. Oh, there is an image. Earlier when I was looking at these slides, my image had disappeared. Next slide, please. So those with, let's see here. So here's an example of a best practice advisory in our health record that alerts providers when a same-day crisis response plan is needed. Some RNs have also been trained to back up social workers when needed. Next slide, please. The crisis response plan is set up as a customizable template in the electronic health record. And this is an example of a real one filled out with identifiers redacted. So it includes the basic components of the safety plan designed by Barbara Stanley and Gregory Brown, many of you may be familiar with. First, warning signs of a suicidal crisis. For this person's case included staying in bed. Second, coping strategies, for which this person included going to laser therapy, going for a walk, calling their daughter. Third, identification of a support person. For this person was the ex-husband. Fourth, limiting access to lethal means. For this person included a firearm. And fifth, professional resources to reach out to for help, including suicide crisis lines. In our template, we also document the follow-up plan. For this person was to call and schedule an appointment with a mental health specialty provider and connect again with the social worker, the primary care-based social worker in the meantime if needed. Next slide, please. I won't cover the screening and assessment work we integrated for alcohol, cannabis, and other drug use in detail today, but the tools and process that we used are also described in this expert change guide, and that's something that's freely available online. Next slide, please. I do want to share some helpful tools we developed for our providers to address alcohol use, including a brochure and a video that explicitly addresses stigmatized language and some common misconceptions about alcohol use disorders. For example, how we're moving away from the term alcoholic and instead use mild, moderate, or severe to describe the range of problems associated with alcohol use. Another resource referenced here is a decision aid, which describes different evidence-based approaches individuals can use to change their drinking patterns. And a public link to that resource is also included on this slide. Next slide, please. We've also developed a brochure to help primary care providers have conversations about cannabis use, which was something that providers in our system specifically requested. There's also a separate ongoing effort to address opioid use disorders in primary care. My good friend Amy Lee, pictured here in the top left-hand corner of this picture, was a mental health integration practice coach, and she's now building from that work to address OUDs in primary care at KP Washington. Next slide, please. Another resource we just started using was developed by Emmy Betts at the University of Colorado called Lock to Live. Emmy and her team developed Lock to Live to help providers help individuals at risk of suicide make decisions about securing lethal means, particularly firearms. Next slide, please. At KP Washington, we've developed a way to integrate Lock to Live into our crisis response plan template I showed you earlier. So now there's a shortened link and a QR code that providers can easily integrate into that safety plan. Next slide, please. We've also developed a handout to help providers introduce this tool to patients based on guidance we received from our members, including firearm owners and individuals with suicidality. I've also included a public link to this handout on this slide so you can read it over at your leisure if it would be helpful. Next slide, please. Another resource our providers use is nowmattersnow.org. This is a website my collaborator Ursula Whiteside and I developed with a grant from the National Institute of Mental Health in partnership with individuals who've experienced suicidal thoughts and attempts. One of the resources available on this site is an emotional fire safety plan, which can be integrated pretty easily into the Stanley Brown safety plan intervention relatively easily. Next slide, please. We've also begun exploring how to better integrate alcohol-related care into suicide care. This graph is included in the paper referenced here and shows that suicide attempts within 90 days of a visit with a mental health provider were substantially higher for individuals reporting suicidal ideation. That's the orange line in this figure, but especially high for those who reported high-level alcohol consumption on the Audit C. The Audit C is part of that 7-item questionnaire I mentioned we use at KP Washington with all adult patients at least annually. This research underscored the potential value of addressing alcohol use collected via Audit C and suicidal thoughts reported on the PHQ-9 together for purposes of suicide prevention. Next slide, please. Finally, we continue to ask KP Washington patients about how they perceive and experience mental health integration. These are results from one qualitative study we did a few years ago on how individuals experienced questions about suicidal thoughts at a primary care visit. All participants in the study believed being asked questions about suicidal thoughts was appropriate and valuable, but also described how they experienced or anticipated experiencing stigma and or loss of autonomy, and often weighted their hopes with their fears before disclosing suicidal thoughts. And this work in particularly reminds me of some of my mom's experience I talked about at the beginning of this presentation, particularly her fear of being hospitalized again. Next slide. And with that, I am back to where we started. I hope that what you take away from this presentation is the message that providing team-based care for mental health and substance use in primary care is feasible. And there are a variety of resources available now to help primary care teams do this important work. Next slide, please. I want to close with a quote from that qualitative study I just mentioned. The last participant that I interviewed said, "I wish it all could have been done over again with my primary care provider, actually. To be a good listener when I'm there crying and not knowing what to do, that's the thing. When someone's coming in and they're vulnerable and they're depressed and they're overwhelmed by emotions, I'm sure it can be intimidating. It's just like compassion. Don't try to fix it today. Try first just to listen." And next slide, please. So thank you again for your time today. This is a recent picture of my daughter in contrast to the picture I showed at the beginning. And it sounds like we're holding questions till the end. So with that, I will wrap things up and turn it over to the next presenter.
All right, and I am unmuted, which is good. And I'm going to set my alarm for 15 minutes. So thank you so much, Julie. That was awesome. I actually have some questions, but I'll wait until after mine is done and see if the panel or the audience had any of those same questions. All right, so my name is Dr. Bridget Beachy. I'm a licensed clinical psychologist by trade, and I'm the Director of Behavioral Health at Community Health of Central Washington, which is a federally qualified health care system. And we have 5 primary care clinics and serve close to 30,000 patients. And if you were on recently for the Washington State Accountable Community of Health Learning Symposium, I also kind of did a talk on our program. So excited to talk a little bit in more detail today. I think it's also very important to point out that many of our patients have very low incomes. We also have a nice cultural diversity and mix of folks, and a very large Latinx population, which is super great. And many of which, up to 10% actually require care in another language. So just really happy to be able to serve such a diverse folks. And in our system, this large primary care system that we have, we operate via the primary care behavioral health model. And essentially, this PCBH, as we call it, the PCBH model or framework, is really designed to fortify primary care and help get a lot of resources for mental and behavioral health on site to have access to patients and be able to make the behavioral health provider a member of the primary care team. I think that today I really want to highlight how much growth we've had and how much this is largely due to the response of the medical teams, the medical system, and the patients. And as Julie had said, this is very, very, very needed. Folks want to talk about this. They see it as part of their healthcare, and being able to be on the team is so important to us to be able to provide patients with the care that they need right then and there. Okay, you could go to the next slide. All right, and then probably click through. I know it's a little bit on a delay. Okay, so our philosophy of primary care behavioral health, or PCBH, there's a wonderful article that was written in 2018 that really defines what we're trying to do here. The GATHER acronym is a mnemonic for behavioral health providers and the whole system really to kind of understand what the role of our licensed behavioral health providers are on the team. So essentially, again, we have teams of psychologists, licensed mental health counselors, licensed clinical social workers, licensed marriage and family therapists. Essentially, they are a licensed mental health provider by trade. They're brought into the primary care system to work as a generalist. They are to see all patients, all kinds, all ages. Sorry, I think my, I don't know if you guys heard that. We are available on demand, and sometimes I get messages through. So if there was a ding, sorry about that. But yeah, so essentially our behavioral health providers really want to be able to see any patient, any kind, any age, for any condition. We want to be very accessible, so we really, really highly prioritize on-demand visits. So right then and there, and we're not talking about necessarily a meet and greet. We're talking about doing an actual visit on demand. We really don't want our patients waiting longer than 15 or 20 minutes for a behavioral health provider, behavioral health consultant to get into the room. We are team oriented, so we're working with the nurses, the medical assistants, the PCPs. It's very important for us to be highly productive. I know that that's hard for some folks to hear, because sometimes you think highly productive and you think, okay, quick, efficient, get them in, get them out. That's not the way we're looking at it. We're looking at it as being accessible. So if a patient is in need, we can provide the service right then and there. And when you do that, turns out there's a big need and you will stay busy. So that's very important to meet patients where they're at and to be available to the medical providers and the team. We want to be educators, not only to our patients and kind of a lot of that psychoeducation, we also want to be educators and have that bi-directional interprofessional collaboration with the whole medical team. Literally can't even tell you how much I've learned from medical assistants and the PCPs and nurses and vice versa. So it's been a really cool process. And then the R for routine, we really want to highlight that meeting with a BHC is a normal part of primary care and your health service. And we stick with kind of the terms behavioral health because we want to emphasize that in addition to mental health, in addition to substance use, anything that impacts a behavior, the behavioral health provider can be brought in on for that. So for example, if somebody's having a hard time with treatment adherence, somebody's having a phase of life, difficulty in their phase of life, maybe going through divorce, anything that involves behaviors, we as behavioral health consultants want to be involved in. The other thing that really guides our philosophy is the 4 C's of primary care. So if you look at in our country, what are we trying to do with primary care? We're trying to be the first contact for folks in the community. We want to be a place where there's continuity. We have continuity of care. We want to be a place where there's comprehensive care. We want to be able to coordinate. That's where a lot of patient-centered medical homes have really jumped off as. So we want to be the place that when something's going on with a patient, that they think of and they come in. So as a behavioral health provider, I want to be a part of this process. I want to help primary care to achieve the 4 C's. When something's going on, I want folks to think of, hey, I have resources. I have a BHC at my clinic. If they're going to go see a specialist therapist for maybe some specialty, say PTSD treatment for EMDR, and I still remain their BHC the same way they still have their PCP. So even if there is a referral that's made out to the community, I'm still involved. I'm still a person's BHC. The same way, if you think about your doctor, they don't stop being your doctor. They're always your doctor. Okay, you could go to the next slide. Turns out every year, since we really have beefed up the program, in 2016 is when things really took off. We want to make sure that the service that we're providing is very useful to primary care providers. And the reason why this is so important is because we know how overburdened primary care can be. And so for myself and my team, if we are able to support the primary care providers and allow them to do their job and have that backup, that safety network, knowing that they're not just out here on their own. If something were to come up, they can get the BHC right then and there. That is so absolutely important to us. So we asked them via a survey on a 1 to 5 Likert scale, with 5 being essentially the highest. We're looking at and saying, how satisfied are you with the behavioral health services? How helpful are we as BHCs to your patients, the PCP's patients? How helpful are we to you? Are patients able to be more, the actual most up-to-date term is adherent, not compliant, so sorry about that. We have updated that on our newest survey. And BHCs make my job easier. So if you can look at the numbers on the far right-hand side for 2020, it looks like we're doing our job with regards to making sure that we are available for our PCPs and supporting them. It's almost a 4.8 for satisfaction. Helpful to patients, 4.8. Helpful to you, it looks like there was maybe 1 person who gave us a 4 out of 5. The other 38 individuals gave us a 5. Patients to be more likely to be adherent. I mean, 4 is pretty good. It's very hard for patients to always be able to execute the complicated plans that they got going on while managing life and making their job easier. We're at a 4.6. So this was very important to our team. If you go to the next slide. And getting buy-in from physicians is so important. And some really awesome qualitative responses I want to share with you guys. We had a section on this on the survey essentially where they can write in, and we were very careful to say, we kept it neutral. We didn't say what is your favorite part about BHC. We said what is something you'd want to improve and what are general feedback to the BHC team. What do you want that to be? This is the stuff that they wrote in there. I've come to believe this brings more value to the care I can offer patients than any other service in our clinic. One of the main reasons I came and will stay, BHC is well integrated into clinic and very much appreciate warm handoffs and co-visits. I will never practice without a BHC partner on the team. Love them. I like that one. Love them. Makes our job so much easier. And keep going down to, this is the best innovation in primary care in my entire career. It is vital to good patient care. So getting buy-in from the medical providers is super important. Next slide. It's just not enough to be supportive to our PCPs, right? We want to have a valuable service to our patients. So we have a survey that goes out, patient engagement survey, satisfaction survey that goes out to all of our patients, and they include BHC in this. And so it's very important to look at these numbers and track it over time. And the really, really cool thing about it is they compare our program to other programs that often use more of a traditional format of these 60-minute visits, whereas our visits are way closer, anywhere from, honestly, anywhere from like 10 minutes up to 45 minutes, but most commonly 25 to 30 minutes. Most commonly, we're going to see about 8 to 12 patients in a day. So that's most commonly the format. And so if you're comparing that to the traditional model of 60-minute appointments where, you know, maybe there's 8 open slots in a day, maybe a couple people no show, maybe you're seeing 6 patients. I think it's very important that if you're going to have this primary care pace, that we make sure that it's a good, valuable service to patients. Well, comparing the numbers, it was absolutely within the range, if not in some cases even higher with regards to patient satisfaction with provider listening, provider time spent. That one is, you know, huge. Provider explanation of care, provider knowledge of behavioral health and medical history, and overall satisfaction. So again, this score is from 0 to 100. So we're getting a lot of excellence coming through to get a score of 94, 91, 93, 91, and 90. And again, some of the misconceptions of integrated care is it's too brief, it's too fast, patients won't like it, they don't want it. That's not how we're looking at it. We're looking on it as being, they need to be more swift than 60 minutes because we have a lot of patients we need to work with. We're looking at it as being accessible. We operate on the same kind of pace as primary care providers. We are not necessarily time-based. We're more, did we get the job done for that visit based? And again, don't forget about the longitudinal relationship. You can go to the next slide. And one more through with the click. So we got tons. We have 5 years worth of qualitative data directly from our patients. This is the most up-to-date quarter. So I just actually took a snapshot of our quarter and put some of the highlights in there. As you can see, they're describing us as being interested. They were able to understand. They were friendly. They listened to me. I've had that same provider for years now. So there's that longitudinal relationship that will develop in primary care. It was heartfelt. So the very opposite as being brief and sterile, helpful and knowledgeable. They make things comfortable. We want to reduce stigma. And the BHC was informed, which is good. They liked the rapport they had. So all this stuff is making us feel like we're getting that feedback that patients are connecting. If we're able to bring it to them, that's how we reduce stigma. Different cultures as well, and different just belief systems. We can get all into that. But being able to just be there alongside of your medical providers, see patients right then and there, it really breaks down the barriers. You could go to the next slide. This is our team members and our growth. I joined the team in 2014. I took over, I guess, or actually not took over because we didn't even have a director. I became the director of our program alongside my kind of co-director of our educational program that we started for our pre-doctoral and postdoctoral fellowships in 2017. I took over the director of clinical side in 2016. And so essentially we beefed up both our regular core BHCs as well as our training programs. And we actually added a coordinator to our team. So our BHC team members have basically just skyrocketed because of the demand. You could go to the next slide. Our encounters, my goodness, we are up to close to 13,000 prorated for 2020, 13,000 encounters with our little team. Our BHCs have, work with so many patients, and they're able to reach so many lives. It's really cool. We have a penetration rate at our main clinic of 25%, which means if you take in a 12-month snapshot, every single patient who came in for a medical visit, and you said, well, how many of those folks had a visit with the BHC in the same 12-month snapshot? 25%. So 1 in every 4 of our primary care patients have had a meeting with the BHC. And again, we're able to continue to grow because of the demand from medical providers, the whole system, and our patients. Okay, you could go to the next slide. Our workflow, it's really awesome. We essentially let everybody in our whole system know what a behavioral health consultant is, how to describe us, how to introduce us. At the beginning of every half day across all of our organizations, they mark who is the physicians that are going to be there, the APCs, and which BHCs are on in clinic. If the BHCs are on in clinic, they're going to have both scheduled and same-day visits, so they're kind of staggered. We have Microsoft Teams, so if anybody on the team, from a medical assistant to a nurse to a scheduler to a PCP, if they need a behavioral health provider right then and there, they Teams us, they look at everybody who's on. And so if, like, I was on in clinic this morning, that's where I just came from, they would put Dr. Beachy and the other 2 BHCs who are on, and then we would respond within 3 minutes to let them know how long it's going to be. We try to get there in less than 15 minutes. We don't miss very many handoffs, but it does happen from time to time. And in that case, we would have them scheduled, but we really highly prioritize doing a visit that day. And we normally do a very quick handoff with the medical provider or the medical assistant, whoever's doing the handoff. We try as much as possible to see the patient right in the exam room. My quote unquote office is an exam room that's in the same hall. We normally have 3 or 4 behavioral health consultants at our main clinics and throughout all of our clinics. The BHCs see patients in the same hallways, the same exam rooms. You wouldn't even know the difference, other than we have a little flag that we have popped out that says BHC, but all the rooms have a flag to indicate that we're in there, because once again, we don't want to make any distinction between healthcare. We use all the same operational processes that took a lot of years, and it's still an ongoing process, but the same operations processes that are in place for the physicians and the APCs, BHCs use. I don't schedule any of my own patients. It's through the operations. You could go to the next slide. And I'm aware of time. I just hit that 16-minute mark, so I'm going to wrap it up in 2 minutes. So when we meet with patients, we go over their love, work, play. It's very important to us to find out these really critical, man, I need some water so badly right now. And there's nobody down here. I'm all by myself. So these are the things that we like to go over with patients and find out their love, their work, and their play, and their health behaviors. And you can go to the next slide. We have sample contextual interviews, as we call them, of this love, work, play, where we're finding this information out from patients. You guys can go to YouTube. We actually have about 5 of them. This is just 2 examples. So you could see, well, hey, what do the BHCs do when they're actually in the room? We have, like I said, up to about 5 simulations on our YouTube page. We also have YouTube videos about how to craft a primary care behavioral health intervention. Next slide. And these are the screeners that we utilize, which these are common ones that are used in primary care in general. Then you could go to the next slide. All right.
Okay, thank you so much. Beautiful. Okay, so good afternoon, everyone. My name is Naomi Herrera. Oh, as I spin us across, I'm using that little part of my mouse. Okay, beautiful. So my name is Naomi Herrera, and today I'm going to be speaking about my experience as somebody who received this incredible wraparound care and support through similar programs as to what was shared. Before I do share, I would first like to briefly introduce myself. I am a person who lives with mental health conditions and someone who is absolutely passionate about recovery and sharing trauma-informed practices with essentially anyone who will listen. I worked as a crisis phone interventionist for 2 years before becoming a peer support specialist for a mental health organization where I spent the next 6 years of my career. So suffice to say, I had a good amount of expertise in managing crisis from both my personal and professional experiences. And what's important to note is that even with all of that expertise that I had a crisis situation arise where I felt lost, hopeless, and unsure of what to do next. I would like to acknowledge that what I'm about to share does have the opportunity or the possibility of being emotionally activating to those who are watching. So my ask is that you take care of yourself, even if that means stepping away from the computer. I'll be sharing relevant pieces of my experience with this program, and that's going to actually include some of my medical records and medical notes. So I'm going to take us now back in time to October 2018. After completing a 3-day trauma-informed training, I met up with my partner for dinner. A situation occurred that activated a trauma that I had survived 8 years prior. And it caused me to start experiencing symptoms of anxiety, panic attacks, along with other experiences from my PTSD. It was absolutely disheartening, to say the least. And still I carried on. I started with weekly therapy sessions and was utilizing the wellness tools that I had created over the years of being in recovery. So a few weeks later, I was on my way to work and made it to my desk. And then I realized that although I appeared calm and collect on the outside, my inner world was on the brink of a crisis. I excused myself early, and when I made it to my car, which is my safe place, I broke down and experienced a panic attack, and it robbed my ability to speak. I attempted to reach out to my supporters, but I wasn't able to communicate. And I had what I can only try to explain as a vocal tic. So it made it impossible for me to express my needs through words. Luckily, my parents had a deep understanding of my complex trauma and my mental health experiences, so they knew I was in a crisis situation. And once I had a moment of steadiness where I could think in a more clear and concise manner, I drove to a nearby restaurant and called the 24-hour nurse line. And that is when they connected me with the Tacoma South Kaiser Medical Clinic. Absolutely love that place. And I was able to explain my need or that urgent need that I had in that moment. At first, there wasn't a same-day appointment available, and that was crushing to hear. But PA, Noelle Aggie, happened to be near the receptionist, and she could hear this was a crisis situation. And luckily, she had the autonomy to be flexible with her schedule by double booking herself, so I could desperately get that need or get the need that I absolutely needed in that moment and get that care and support. And her notes read, Naomi Herrera is a 34-year-old female who is added on today double booked due to severe anxiety. She has a very complex trauma history and works in mental health. She has been on medications, done EMDR therapy for a while, and was doing well for years. Now, what do you think about for years? So I eventually made it to my parents' home. They drove me to my appointment. And when I arrived, get some water too. I was ready to experience some relief. And luckily, I experienced that with Dr. Aggie. She played a critical role in my wellness, not only in getting me scheduled for a same-day appointment, but in the way that she spoke to me and treated me. She treated me like I was a human of deep value and worth. With a history of seeking mental health crisis support in ER departments, even the one my father worked at. I was expecting the worst when I walked into that office. I was expecting to be ignored, talked down to, and dismissed like I had so many times before. But luckily, this time, the experience was nothing like that. Upon meeting with Eggie, I immediately felt safe. I felt supported, and I knew I was going to be taken care of. After our appointment, she called the psychiatrist for a virtual consult and connected me with a social worker, Christy Egan. Christy was the second miracle worker that came into my life that day. She spoke to me with dignity and respect. Even though at times I was, in her words, presenting as restless, intense, short attention span, lack of concentration, unable to focus, and experiencing tremors. She didn't speak down to me like a lot of medical and even mental health professionals had when I was experiencing crisis in the past. I felt validated and seen in a time when I absolutely needed that. Christy treated me like I was a valued person experiencing a difficult situation, and her notes about me reflected that. And I'm going to share what she stated. Though she has worked with many of the leading spiritual providers, therapists, healers, and other recovery and trauma-based work, she's still fighting the susceptibility of triggers from both macro and micro levels. She endures panic attacks, even though she thinks wholeheartedly that she has PTSD. Although she admits she knows it's not exactly possible this time. With the level of complex trauma she has experienced, she has participated in countless hours of healing, which have afforded her a steady and safe enough life. However, with recent events, she's experiencing a level of panic and PTSD symptoms that feel to Naomi as if she's starting all over again. While this is not true, she is certainly dealing with managing symptoms that are debilitating and dramatically affecting her ability to work in the environment that has her containing others' pain and suffering. So talk about trauma-informed approach and wraparound care. So not only in this experience, at my highest need, did I receive top of the line care and support at my appointments for my follow-up care, but my records also show that I was seen as a whole person, not just a patient or another patient, or a number to meet productivity expectations. I would hope that these two providers are afforded the opportunity to be acknowledged for their outstanding work and to train others in the field so we can transform the way that medical systems support people who live with behavioral health conditions. Because of these two dedicated individuals, I was able to return to work just 2 weeks later, interview for the job I have today as Coordinated Care's statewide peer support liaison less than a month after the fact, and begin working in this new role on January 7th of 2019 as a whole person. To this day, I still experience mental health symptoms, and I may continue to do so for the rest of my life. Healing is a non-linear journey, and through each worthy obstacle that I overcome, I'm able to find lessons and blessings that serve to strengthen my mission to use my lived experience to inspire hope to peers and to drive program innovation in our physical and behavioral health systems. Thank you so much for listening, everybody. We have our references here. And now I believe Stephanie will be opening up for questions.
Yeah, first off, I want to thank Naomi. Thank you. Also thank Dr. Richards for telling your personal story. And if you guys want to keep your videos on. So we do have some questions in the chat or in the Q&A already. So there were some questions around how in primary care you address other conditions other than alcohol use disorder. So other substances, including opioid use disorder.
How do we address the? Or
Yeah, go ahead, Bridget.
Yeah, is it regarding stigma or just in general?
Both in stigma and how you screen and kind of manage that within the clinic.
Okay, and good thing I got some water. So all you out there, I am not an amateur presenter, but I forgot my water, so that was rough at the end. So I appreciate y'all sticking with me. So essentially, part of our contextual interview that was on one of my slides, we ask, the BHCs are trained to ask about substances every single visit. So after we go through the love, work, play, we go into caffeine use, nicotine or tobacco, move into alcohol, marijuana, illicit drugs. And I think that it has a lot to do with the way you approach it, that that this is something we're going to talk about and that it's okay to talk about. And I'm your ally here. This is not a zone so I can label you as something. This has everything to do with my job is to join with you and help you on your journey. And I think a lot of it has to do with how we train, that this is just a normal process. This is something we're going to do. And it's not off limits.
Yeah, I would just echo that. I think that's a really important point that Bridget makes, just about the collaborative nature and how these need to be collaborative conversations. It's not, it's not like the provider making decisions for the patient, and that's just something that we've heard continually, kind of about this integrated approach and collaborative decision making, just being so important.
And Dr. Richards, I don't know about from what you've seen, but the other thing that's really important to us is that if somebody does not want to work on something related to their substance use, that's okay too. People have a right to make a decision about what they want to work on or not. And sometimes if you're able to honor the patient where they are and address maybe something else that's more important, say a divorce, then it will, you address that with them. And that actually helps their substance use to decrease because that was being used. You know what I mean? So we really look at things transdiagnostically. It's very much about re-engagement in the person's life versus, okay, well, now you've hit this criteria, so this means that.
Yeah, exactly. Yeah, that's one of the things I heard too. Providers, we learned about, scripting that providers would use and shared that with others across kind of Kaiser when we were doing this work. And, one of the things some providers did was ask permission. Can I address this with you, whether that's an opioid use disorder or if that's, alcohol use or cannabis use? Can we talk about this today? And patients could say no, and say, but it doesn't, and that was completely their right. But it, just was something that the idea would be to, it might serve as something that they would think about and potentially open a conversation about later on. But yeah, exactly. It's their decision.
Hey, we have another question around, have you been able to successfully coordinate care with outside agencies like schools or community crisis teams to coordinate care? So Bridget, I'll start with you.
Yeah, I think that we actually have a care coordination team that is a non-clinical role. So all the behavioral health providers are a clinical role, and a lot of the connection happens through our care coordination. So we have master's and bachelor level social workers and case managers, and so a lot of the information happens that way, and it's really helpful for everybody because a lot of those that could be very time intensive to hunt down these connections. And so if the behavioral health provider is able to kind of move on with their day and see as many patients as possible, then you're able to kick that to the care coordinator, that non-clinical role where they can kind of do some of that work.
Yeah, and something I'll mention, I didn't cover this in my presentation, but something we've tried it in the Kaiser system, we have clinical resource specialists now, and these are non-clinical personnel who really try to make those connections to community resources in the clinics across our health system, which is predominantly Western Washington, but also Eastern Washington. So really being sort of the local experts and, keeping up to date on what resources in the community are available for our patients. So that's something that's been really helpful for us here as well. I also just briefly wanted to say thank you to Naomi, while I have the floor for a minute, just for sharing your experience. And it was just really wonderful to hear about. So I just want to acknowledge that. Thank you.
Great, and then we have a question for Bridget about how you fund your program.
How I fund?
Yeah, how
the
program funded.
Yeah, so we have, we bill for services, and that takes care of a lot of the financial aspects. We also, like I was saying, are very productive and see a lot of patients. And again, I always feel uncomfortable saying that because it is not about, like you said, churning folks through. It is about the fact that we have high demand, and we've created a system that allows the providers to be accessible to the patients and vice versa. And then we also receive, we're an FQHC, we receive HRSA funding. But just looking at our books, to be 1,000% honest, we would probably break even without grants at this point. But that is, we also are a very mature system, and have, it was not always like that. And I have to, like I said, go back and look at the books to make sure that's completely accurate at this point. But when COVID hit, we actually surged. And now with telehealth availability, we actually we're able to see more patients.
Great. There was another question, Bridget, for you that maybe this is part of the YouTube links that you sent, but what does the 30-minute visit look like?
Yeah, that's a really important question, and definitely would encourage folks to do some more research on that, because it's, you know, not an easy answer. But in a nutshell, we have a very clear introduction that has informed consent that says very clearly what we're going to do today. We're going to be meeting with them for about 25 minutes. We're going to be working with your provider, chart right into your record. We say what we are by trade, and that we're a member of the primary care team. We launch right into the contextual interview, and we ask about a person's living situation, relationship status, important family, important friends, what they do for spiritual or community life, and what they do for income, as well as hobbies, passions, things that are important to them, and then move into the substance use and the health behaviors. We're all trained in it, highly trained in it at this point, and can get through the first part of that about 20 minutes. And then the intervention is directly created from the information that is in the contextual interview. So it's not really a separate process, because you are really paying attention to the devil's in the details, right? And then you're using that as the intervention with the patient. So it works really good. Sometimes a visit can go 35, 40 minutes. Sometimes a visit can go 22 minutes. The most important thing is that you meet the patient where they're at, you get something done, and most commonly it's going to fall in about 28 minutes.
Great. And then this is probably going to be our last question. How do both of your organizations train behavioral health therapists to interact in the primary care setting? Onboarding, and is there ongoing training that you provide? So Dr. Richard, I think you can start first.
Sure, yeah. So this is really sort of evolving over time. But yes, like, so when primary care social workers are brought on board, there's an onboarding process. I mean, and they're really, I think, at this point, you know, part of a lot of their learning is just going to be, you know, across the team that they work with, and they're really just taught that they're like the local the experts in their clinics, kind of owning this work, and that's what I've heard them say, even the ones that I've interacted with, because I'm a Kaiser patient myself, you know, when I go in. And so, you know, they really, like, I think that's been helpful, and take it upon themselves to do a lot of cross training. I think that's probably like where folks learn the most from their peers. That's, you know, my sense is kind of a non-clinician, but I'll let the clinician on the call field that one.
Yeah, we have an intensive onboarding, because you basically have to make your own at this point. It's 8 weeks. To be honest, it's probably closer to a year. And we have multiple books. I literally am onboarding somebody. She started Monday. I have a stack of books. I have a stack of videos, a stack of articles, and then it's a shadowing process with all the BHCs as well as physicians and other folks in the organization. So it lasts about 8 weeks because of the extensive, it's completely different than what folks are trained in. And so you almost have to grow your own, and that's basically what we're doing at this point. And email me, because I have all those resources all listed out.
Great. Well, thanks so much. I don't know if your email's in the slides, or we can put it in the chat for folks.
I'll put it in the chat box.
Yeah.